Hello, I'm Matthew Weinstock, Managing Editor for Modern Healthcare. Thanks for tuning in to the latest edition of the Checkup. Data from the Centers of Medicare and Medicaid Services over the summer showed that dual eligibles, those beneficiaries who are eligible for both Medicare and Medicaid, had among the highest COVID-related infection and hospitalization rates. Commonwealth Care Alliance in Massachusetts focuses on serving this high-risk population. I'm pleased to be joined today by the organization's CEO, Chris Palmieri, to talk about ways of caring for that vulnerable patient population. Chris, thank you so much for being with us. We know it's a busy time for you.
Yeah, it's great to be here, Matthew. Thank you.
So give our audience a little bit of background on CCA. Not everyone may be familiar with you. I know you've got close to 40,000 high-risk, dual-eligible type of patients in your membership, right?
We do. We're a nonprofit organization headquartered in Massachusetts, and we're dedicated to caring for the exact individuals you described who are dually eligible for Medicare and Medicaid. And all of our consumers have complex medical, behavioral health, and social needs, and that includes people with disabilities as well.
And so, as I said at the outset, CMS had some data earlier this summer that showed that those high rates of infections and hospitalizations for that patient population. What were you seeing, and what have you seen among your members?
No, it's thank you for drawing that correlation. So we have, and again, our data is preliminary because we're still very much involved in COVID. But as we looked at our data, of our 37, nearly 40,000 beneficiaries, we've had about 1,262 total cases. And when we look at our cases based on the same groupings that CMS grouped its data around complexity, those with severe and persistent mental illness, we had 1,399 cases per 100,000. CMS's data showed 3,794. Our disabled population, fortunately, did extremely well. We had 300 cases against CMS's data of 1,663. And those with ESRD, we had 75 cases versus CMS's data of 7,665. So we did do quite well through this. And again, I want to caution the listeners that we're still very much in this and continue to be concerned about the well-being of our populations.
Were there certain things that you were able to do to reach those patients? I know one of the things that I wanted to talk to you about was your use of data analytics to kind of target services, but how, when COVID started to roll out in Massachusetts, did you start to reach out to those patients?
Yeah, so great question. I mean, philosophically, our approach has been that we put people first as an organization, and we recognize that our populations are the most vulnerable for being impacted by COVID-19. So as you correctly pointed out, like everyone else, it was a struggle to continue sort of routine operations. And at a time where the world was shutting down and socially distancing, we weren't able to do that. Our primary care clinics, of which we have 2, remained open. Our inpatient mental health facilities remained open. And we assembled a team of individuals that, with the appropriate PPE, was able to continue visiting our most vulnerable in the community. And then we did everything telephonically, and we were able to reach our population quite effectively and quite often. And as you described, we did use data analytics to target services. We have internally to our organization a predictive analytics team, and we created a COVID-19 dashboard. And effectively, that dashboard allowed us to have up-to-date risk-weighted guidance for our care teams that were engaging our members. We built that on the Google Looker platform, and data from our electronic health record, which included not only medical information, but claims and external data, as well as social data from LexisNexis, is synthesized to produce this dashboard, which again allowed us to focus on those that had the highest probability of sentinel event first. And then obviously we focused on our entire population, but this prioritization really helped us at the height of the crisis.
So I'm curious about building that platform. Obviously, I'm sure a lot of organizations either are, trying to reach with third-party vendors to do it. Those are at larger scale, could probably do it in-house. You were able to do something. What's the complexity of building a program like that on the fly to make sure you're able to start to reach patients right away?
Well, we already had inroads into building data monitoring tools, and it was the Google infrastructure that allowed us to scale this very rapidly. And it's something that, now as an output of COVID, one of the bright things is we have this wonderful tool. But we had the fortune of very talented data scientists, one of which is Vic Kinesia, who is a physician that oversees this process, so really understands what things look like both from the bedside of a patient, but also from the inner workings of a complex organization like ours. And this tool ended up helping our over 400 care managers get what we call action boards from the monitoring dashboard 3 times a day. And that included data that highlighted, again, the most urgent matters that folks needed to be focusing on in real time. And we continue to think about and evolve the tool. And again, it's been in a very fortunate, bright spot at a time where we've had, just a tremendous amount of challenges, both in Massachusetts and our country in dealing with this.
Sure. And I'm curious about that real time. So you were pushing information out to folks who are visiting patients in their homes on the road, right?
That's correct. And that was helping us, again, prioritize the SWAT team, which wasn't all 400 people that were going out. So we needed to make sure that those that were able to go out into the field knew exactly who they need to see and reprioritize their days if they needed to do that. These were customized for each of our care coordinators. And again, it was all about what's the actionable insight that you need so that you can deliver the relevant care. It also provided side-by-side environmental and personal factors that obviously impact each patient and the directives so that we can minimize the risk. So again, it's been a very seamless and fluid process for us.
Sure. I'm curious too how you balanced, and I'm sure this data fed into that, the telehealth versus in person versus in one of your clinics. How does that process work, and how do you know which patients need which service?
Yeah, no, it's a great point. And as you pointed out, we have nearly 40,000 consumers and only 2 primary care clinics that bookend the state. So we have to rely on a network of community resources. And one of the things that has been happening during COVID is the resources that were available back in January and February of this year were closing for a variety of reasons. And this tool allowed us to identify if there were access points for healthcare that were no longer going to be available. And that helped us not only balance where we were going to send our staff, but how we reprioritize seeing people using telehealth channels. We, in the early days, developed a protocol to find the right balance between care at home, telehealth, and the sort of legacy in-person care that we had provided either in a clinic or in another outpatient setting. And we focused on questions such as what are the most urgent needs, what absolutely could not be done via telehealth. We had to take into consideration the supply of PPE because we were not an acute care hospital system, so we weren't the essential organization that was going to be receiving the same stockpile as those treating people on an inpatient basis. We found pretty early on, fortunately, that most of the necessary at-home visits were centered around skilled nursing care, blood draws, wound and dressing changes, medication adjustments, or delivery of medications. Other things could be completed over the video channels that we all know today as telehealth. We were able to leverage advanced practice clinicians, so in our case, nurse practitioners and physician assistants, to take over the bridge of prescribing medications for members that couldn't connect with their traditional PCP. And we realigned that work so that our clinicians who were previously in the field could take that on as telephonic care partners.
Well, it's a lot of stuff you had going on. And I know previously, a few weeks ago, you talked to one of our reporters, Ginger Christ, about some of the things you had done for your staff to keep them safe and keep them remote. Maybe you could talk a little bit more about what you did there.
Yeah, I mean, first we pivoted completely and sent our entire workforce home in the middle of March. And prior to COVID, the longest an employee had been home or a workforce had been home working remotely was from a snowstorm and no longer than 24 hours. And we are now, I believe, in 181st day, roughly. So 6 months later, our infrastructure has performed flawlessly. We've had some challenges with third-party software applications, but most of that was resolved within hours. We had sent our workforce the equipment that they needed, not only the traditional computers and screens and mouses and keyboards, but we also provided those that needed it, desks and chairs, so that they could do their work effectively and efficiently. We also have been concerned about the stress of all of these changes on our employees. We provided everybody a day off in addition to their regular time off, and we asked them to take that time over the Memorial Day weekend. And we also relieve the burden of folks being concerned about when do I need to come back to the office? And right now we're thinking about a date in 2021 where folks will come back, because we recognize that people have the stress of trying to resume their traditional lives, their children going to schools while having to continue to do a role in our organization is so critical. But at the same time, we wanted to make sure that they had the flexibility to manage their personal life as well.
Well, and that's coming up more and more these days, is sort of the post-traumatic stress that staff may feel once we're past the pandemic. Is that something you started to think about, or are you still in the throes of just COVID, so you haven't been able to really think about late 2021 and what your staff may need then?
No, we've been thinking about it actually since the beginning of the pandemic. We've had teams that have been thinking about our members, and teams that have been thinking about our employees, and teams that have been thinking about our workforce's mental well-being. And the first thing is it's amazing, because in the first 90 days of COVID, employees were very frustrated they couldn't come to the office. And what we've seen in the later stages is that folks have created new norms and customs of working at home, and now are inquiring as to if they ever need to come back. We have, over the last year, centralized a lot of our office space into fewer locations, and we've renovated those and built beautiful new office space. So I'm constantly reminded when I walk by one of our facilities each and every day that I'm here in Boston that what a beautiful facility that right now is sitting empty. Right. We are not one of the organizations that is turning in our leases. We do think that there will be a resumption to an office-based work environment at some point in time, but we are not rushing that, and we are very mindful of all the stresses that will impact our workforce, whether that's commuting, the new norms that they will have to follow when they come to the office, the additional distancing requirements that may be required of us as their employer, which will mean that our in-office capacity will be less. And we also put that against the backdrop of the work and where it can be done best. And are mindful of the fact that we will always have the need and requirement for a specific group of our employees to go into patients' homes. So all of that together has created the backdrop, if you will, for us thinking about what the new normal will look like. And we do not want to create an environment that is any more stressful than it needs to be for our employees. We think life right now is stressful enough. Sure. We are cautiously watching what is happening. We are obviously, like everyone, concerned about what flu season may do with mistaken identity of COVID, when a vaccination will come to the market in a commercial way. So all those are factors that we're paying attention to. And I think just the students here in Massachusetts were a rich environment of academic institutions, watching how the students in the universities are performing and what the infection rates will be, and how that is contained, I think, is a good sort of prelude into what things will look like as more and more employees think about coming back to an office environment. So we're learning at this point. Yeah,
sure. I want to switch back to your members real quick and some of the support you're providing for them. If I understand right, you set up about a $4 million program, I guess. I don't know what the appropriate word would be, but set aside a fair amount of money to help them with supplies and goods that they may need that they might not be able to afford. Is that right?
No, that is true. So an early day back in March, before we were practicing the social distancing that we're all familiar with today, I had our leadership team in our conference room, and as we were debriefing from one of our business continuity meetings about how we were going to be executing against what we thought was coming at us, I asked a pretty simple question, and that was to our clinical leadership: are there things that the organization can be doing to ease this very traumatic transition for our members. And one of our lead clinicians, Laura Black, said, our members are going to need things that the benefits don't cover: Gatorade, toilet paper, paper towels, hand sanitizer. Now, little did we know then that a lot of these items would be very difficult to procure. Right. But I left that meeting, called the chair of our board and said, I need $4 million, or roughly $100 per CCA customer. And we're willing to take that out of our operating surplus. And we need to provide that to our members because they are going to need some additional lifeline of supplies at a time where, and again, we thought this was going to last for a few months. And here we are in the 6th month. And we provided that to our members. 40% of our members have taken advantage. We had to programatize it because we are a regulated organization by the federal and state governments. We average about 171 calls each day from members to order new and additional items. We had to increase our call center by about 20%. And we've now, I'm happy to say, distributed more than 200,000 items. And we were able to distribute toilet paper and hand sanitizer, dishwashing liquid, and other things like canned tuna and rice. And we learned a lot. The most requested items were food, things for diabetic care, household products, and first aid and medical supplies. And we think this is incredibly helpful to our members. And it's something that they, frankly, not us, but they found just a lot of value in, and we're really thankful for the organization's generosity. And we just thought it was the right thing to do.
Is that anything that you could see continuing into the future post-COVID, or not really because of the cost of it?
No, I think it's, and cost is really secondary for us. If these are things that are going to continue to keep our membership more viable at home, there are ways for us to continue to explore offering items through CMS's Medicare Advantage Supplemental Benefits Program. And I think these types of lessons, which we again did at our expense in a very large experiment with high stakes, these will inform the thinking and the guidance that we will provide back to, again, those entities that regulate us. So I do see that there's a lot that is learned here, and potentially going back and providing this insight and guidance so that some of these things can become more standard and routine in the future.
Well, great, Chris. We appreciate the time today. There's a lot that we could continue to talk about. We'd love to follow up with you on some of these things, but again, we know it's busy. So thank you so much for taking some time to talk to us and share your experience with us.
Well, Matthew, it's my pleasure and honor, and thank you for thinking of us and giving us the opportunity to tell a little bit about what we did during this really traumatic time.
Sure thing. Thanks. Stay safe. And I'm Matthew Weinstock with Modern Healthcare. Be sure to come back next Monday for another edition of The Checkup.